Hello everyone. I'm delighted to be here this afternoon. Thank you, Imogen, for inviting me along. And hopefully we'll get through this talk uneventfully. I've been asked to talk about watching and waiting and what it means for patients. Obviously, it's a tough journey for individuals, and these are some quotes of some recent patients that are under our care. So we've seen some trends before already presented, and you can see stage 1 and stage 2 accounting for about 80 or 85% of the melanomas that normally present at that stage. So you've established a diagnosis of melanoma. It's been staged. You've had treatment, which just might mean surgery. And your investigations are complete. And then what? So then you enter the murky world of follow-up, where your appointment may be 3 months, and the role of follow-up is designed to pick up these 3 things. So detect recurrence, so picking things up early, detecting a second melanoma in this case. The chances of a second melanoma range between 4 to 8%. And it's also an opportunity to provide support, information, education at the same time. You would have come across already the nice recommendations for stage-specific follow-up, and you'll see that most of them range over a 5-year period, and there's a reason for that. But who's the follow-up with? Might be multidisciplinary. Most melanomas now are treated in a multidisciplinary fashion. The structure of your follow-up would be around the stage of your melanoma. And it begins essentially with a consultation. The consultation involves a history taking. Your clinician, nurse will be asking you questions, delving into any symptoms you might have. But the important part of that consultation becomes the physical examination. This should entail examination of the site of your melanoma, the regional lymph nodes or the draining lymph nodes of that site, examination of the abdomen, and also, if you're seeing dermatologists, it will essentially involve examination of the rest of the skin. Why is physical examination important? Does it make a difference? There's some early data there from 1995, but there's more recent data showing that physical examination is an important part of picking up early recurrences. But actually, patients are quite good at picking stuff up themselves, and there's a very big review in the Lancet Oncology showing that patients themselves, if taught appropriately, and that's the emphasis in the Australian and New Zealand guidance for melanoma treatment and follow-up. And there's a real emphasis on teaching patients self-examination. There's no consensus how often follow-up should be. And there's a great variation across the world from different areas, and it can be anywhere between 3 months to 12 months. And how long should you follow patients up for? 5 years, 10 years, lifetime? All those exist. All those criteria exist, depending on what part of the world you live in. Most melanomas recur within 5 years, and 80% of them will recur within the first 3 years. And it's good work from the Scottish medical group many years ago demonstrating that. So most follow-up programs line up in the UK 5-year follow-up. Obviously, stage-specific, stage 3, stage 4, things are different. So that's mostly focusing on the physical side of melanoma follow-up. And the focus, as doctors often, isn't about the disease, and you often neglect the impact of the disease on the patient themselves. These are some early studies. About 16 years ago, this is not melanoma specific, but just about cancer. And it's interesting how things have changed. This is an in-depth study here looking at what patients wanted. They wanted basic information. They had faith in their doctor's medical expertise, asked very little questions. Hope was an important part of how they managed. And charity to fellow patients. They didn't want to be a burden to the service. They know that the service was limited. They wanted not to ask too much of care. This is a big review by Cochrane. They just look at systematic reviews, and they looked at over 30 trials about psychosocial interventions. What made a difference to the patient? And it was something that we already know. So nurse-delivered interventions, support, education, hand-holding, impacted positively on mood. But there's very few studies on the actual psychology of follow-up. We're going to discuss one or two of these here. You get your melanoma diagnosis, which is a difficult time for the individual. Of course, patients then become consumed with the fear of recurrence. And certain tests begin to be requested in the hope for early detection. And then this is in 1995. And often there's a sort of juggle between clinical judgment, and particularly in that time. And so these tests are done often against clinical judgment. We saw that patients rated follow-up as important, but there was little in the way of being paid attention to their psychology at the time. So another study in 2013 looking at a group of melanoma patients, early stage, showing what the perceived benefits of follow-up and the downsides, actually. You wouldn't think there'd be downsides for follow-up, but this trial is based in Australia, and you can see here inconvenience of travel, loss of work time, and they were focusing that 12 months seemed to be acceptable to patients. I'm not sure in the UK we would accept a 12-month follow-up visit, but that may be geographical. Another group of studies reviewed in this particular journal, again looking at the psychosocial aspects. Interesting bits here, again, common themes. Clinicians sometimes ordered additional blood or images to reassure patients. GPs hesitant to conduct melanoma follow-up. So this is a slightly disappointing finding, despite the date 2014. This is an online survey of patients in Australia, and these are high percentages. This is 2014. So it was. You have to take the research slightly lightly. This is an online basis, so more motivated individuals would be online putting up their data. But you can see the change from that paper in 95, where people wanted little information, a lot more information, a lot of use online as well. In that particular survey then, the satisfaction was low. Again, do you see the theme here? More scans, more scans. And a greater emphasis on the technical care, which is what we said about examining, and not really listening to the patient and finding out how they're feeling through this period in their lives. It's not that we're being difficult as doctors, it's that the data isn't there to suggest scanning in the absence of any clinical symptoms and physical findings or any other abnormalities often yields very little in the way of detecting metastases. And in fact, if you order a CT chest, abdomen, and pelvis, which is a common investigation, that's the equivalent in radiation of 650 chest x-rays. So the question is, how often do you scan patients? And there's an increased risk of, for example, thyroid cancer with CT chest if you continuously scan individuals. Some of the Swiss guidance involve using a lot of more ultrasound. It's not really in our particular guidance, but the Swiss use a lot of this in their surveillance. But essentially, there's not much consensus. So this is looking a little bit more about what coping mechanisms people are using when they're given their diagnosis. And some of these themes will obviously be common, and you will encounter these yourselves, I'm sure. Avoidance, treatment. They found that confidence in team, those that take a more proactive way of dealing with their treatment, they felt that's a way of dealing with things. And obviously some other aspects which you would have come across as well. So their findings on that particular trial: screening for the presence of psychological distress and appropriate referral when necessary, recommending communication skills training for doctors, which we all do on a fairly regular basis. And this routine assessment of patient-recorded outcomes, that means basically tell us how we're doing. Most of the structure of dermatology follow-up, melanoma follow-up, revolves around coming through the skin cancer multidisciplinary team, which is established via NICE in 2006. It's a team approach. The idea is to standardize people's care. Everybody should have the same care. There should be no pockets of care or superior care to other areas. Communication skills is an important part of that. And we get checked what we're doing by peer reviewing. And this individual in particular is a very important part of how we provide both physical and emotional support for our melanoma patients. And they often get a lot of feedback from these patient questionnaires, which tells us and her or him how we're doing. It's important, actually, because a lot of us, it tells us if we're doing things wrong and tells us if we're doing things right. The internet. So there's a big trend in the use of online resources. Some very good stuff out there. But actually, it can make you a bit anxious. A third of the patients surveyed here reported higher anxiety after internet usage once they start pushing in various bits and pieces, and it's a sort of dark alley they're going down. So the younger, female, more highly educated demographics of the people who use online services tend to focus around here. And obviously, naturally, greater anxiety from looking at melanoma than other non-melanoma skin cancers like basal cell or squamous cell. It's a big social media look at by the BMJ not so long ago, looking at a large number of studies showing that the use of social media. You can see discussion forums and social network sites and blogs. And the purpose of these tools really is to facilitate self-care in these individuals. In particular, blogging. They felt that it's basically a cathartic process. So they found that the blogging was useful for emotion management and information sharing. So follow-up should be led by your MDT with clinical nurse specialist support. Patients need to be taught how to self-examine. Patients with multiple nevi, multiple moles need to be photographed. Needs to be photographed with dermoscopy. A picture set should be given to the patient so they can take it home with them and they keep a record as a baseline of photographs. The second remains in your notes. And therefore, you are proactively giving the patients a set of professionally taken images that they can keep an eye on. The whole skin is to be examined at every consultation, particularly in dermatology. And patients need a rapid access pathway. If you give patients a 3-month appointment, they need to know that they can get in touch with you between those appointments. And that can be via your clinical nurse specialist, your secretary, or yourself, and that's open door policy. So, the provision of the psychological impact. A clinical psychologist forms an important part of our MDT, and they run often courses of living with this uncertainty about the possibility of recurrence. And Macmillan fund these training days and fund this opportunity for patients to attend with the clinical psychologist. It's selected for those patients who are struggling with their disease in particular. Follow-up is not a passive process. As our previous speaker said, we need to engage really in conversation. And we learn a lot from our patients, but we don't kid ourselves. We don't know what happens to that patient as they go outside that door after your consultation. Their world is out there, not the 10 minutes or 15 minutes that they spend with you. So you can begin to have a fraction of a thought about what's happening with those individuals. Education plays a really big part in them feeling that they're doing something positive from their point of view. So thank you very much. I hope I haven't run over time too much, Imogen. Some just quotes from patients for our clinical nurse specialists. Thank you very much.